In this episode of the Nurse Practitioner Podcast, Clark Cassone discusses medical marijuana. Thanks so much for your time today, Clark.
Thanks for having me. Happy to be here.
First, tell us about the article you recently published on medical marijuana in the Nurse Practitioner Journal.
Yeah, really excited about it. The title of the article is The Nurse Practitioner Students' Knowledge and Perceptions of Medical Marijuana. And, I was interested in this because I've read articles on pharmacy students, medical students, nursing students' knowledge and perceptions or attitudes. And so I noticed there was a gap, and I'm a professor at Simmons University, and I thought this is a great time to do this. And I was also preparing for my DNP. And so with my chair, who's also on the article, we, looked at these nurse practitioner students and really got a sense that, A, they really want more education, B, they don't feel like they're well prepared, and C, those that had previous use in marijuana tended to have more knowledge about it or felt that they had more knowledge about it. So, these are future nurse practitioners, and there's certainly a possibility that prescribing cannabis at some point will be in their future.
We appreciate your contributions to our journal on this important topic. What's the latest update on how many states have legalized medical marijuana?
That's a great question. I think things are certainly in flux. As of right now, 38 states plus the District of Columbia, which is included in that. And, there's still about, 7 states who have CBD primarily for medical marijuana legalization. Maybe it has the CBD might have a very small amount of THC content. But we know that for Gallup polls, the public does support legalization of marijuana, especially medicinally. And I think you're hard to find people who do not have somebody they know that's using marijuana with some type of benefit.
Thanks for sharing those state updates. What is the update on the possibility of marijuana going from Schedule 1 to Schedule 3?
I get this question with my students. So I teach pharmacology, and it's confusing to have to learn, okay, Schedule 1 medications or substances include marijuana. Also, Schedule 1 is heroin. So how do you kind of understand that marijuana, which actually is now legalized in, 37 states plus District of Columbia for medicinal use, how do you understand that, right? And how do you understand your role as a future nurse practitioner? And essentially what's happening now is the DEA is going to have a hearing to evaluate moving potentially marijuana, which is a Schedule 1, to a Schedule 3. So just to give you a sense of what Schedule 3 is, so Schedule 3 you would find testosterone. Schedule 3 you would find Tylenol with codeine. And Schedule 3, really indicates a lower potential for misuse. And also technically you can have refills on Schedule 3 medications. Now, they might put some specific parameters. And then also to give you some context as well, Schedule 4 would be your benzodiazepines. So for me, I think benzodiazepines would probably move up if I had my say in terms of abuse potential, but it gives you kind of a good kind of sense of where we're at. Now, that hearing still could take years before we see any changes. But I do think the fact that they are entertaining it, I think hopefully means that we're heading in the right direction.
It doesn't seem to make much sense that medical marijuana is still listed as a Schedule 1 drug.
Agreed. Yeah. And, the FDA has not approved any investigational new drug applications to really, put marijuana through a stringent clinical trial and really get to know its safety, efficacy, what's a good dose. And, that's a real shame because, people are using it and they want to have medical benefits, but they're also having to kind of guide themselves or rely on the dispensaries to guide them.
What is the FDA's role in medical marijuana?
Yeah, I think that's a great question because sometimes, from students, I'll get that question, is the FDA at all involved with medical marijuana? And, certainly they are. They are, the ones that are receiving, investigational new drug applications for, new clinical trials. And most of them around, pain or addiction medicine. I think that the changing of the schedule, right, from 1 to 3, that will certainly open up the opportunity for actual clinical trials. Now, they certainly have approved synthetic forms of marijuana like dronabinol. They also more recently approved, Epidiolex for LGS, so for severe epilepsy. So they are, still in a very much so prescription based, right? So this movement from 1 to 3, certainly would help a lot and really guide us as prescribers, to prescribe safely and feel like we know how to follow and set our patients up for success.
Thanks for detailing the FDA's regulatory involvement. What are evidence-based indications for medical marijuana?
So again, I think we lack some of the clinical trials that would certainly be helpful. There are, certainly it's important that we're looking at, evidence-based articles, chronic pain, neuropathic pain. You're going to see, the most evidence in support of. We need more, again, clinical trials. We need more longitudinal evidence to certainly help us and guide us. Also, there is something called nabiximols, or the other name for it is Sativex, that is approved, certainly outside of the United States. So I think Canada, et cetera. It's THC, and it's used for MS and the spasticity that's related to MS. There's, evidence in terms of cachexia related to AIDS. You'll see some evidence on the use of something I use in my own practice. So my practice is in palliative care. We certainly recommend marijuana to our patients, when appropriate. And, for those that have really a more severe or refractory case of, nausea, vomiting, whether it's chemotherapy related or disease related, we tend to start thinking about really adding in cannabis. And I've had a lot of great success with that. So those are some indications, but I think, again, we really need more data. But I think if you asked your patients, the number one reason they're using marijuana, and it's important that we're asking them, is usually for neuropathic or chronic pain.
It's great to hear the emphasis on evidence-based practices. What are important adverse effects to monitor for?
Yeah, I think that's a great question. And oftentimes that also really goes hand in hand with the amount of use. So, higher THC content, more regular use or frequent use, during the day certainly can increase someone's risk for adverse effects. And that could be fatigue, it could be anxiety. There can be some blood pressure lability. So that being, orthostatic hypotension or hypotension and sometimes hypertension. You also can see increased heart rate. Paranoia is a possibility. Euphoria, which is a benefit, but certainly it can be seen as a side effect as well. Dry mouth, increased hunger, would be some to name. Also, with excessive use, you can develop a hyperemesis syndrome, so cyclical vomiting, which tends to lead people to the hospital. And so, again, that's with more excessive use.
Those are important points to keep in mind for monitoring patients. Where should NP start with dosing medical marijuana?
Yeah, I think this is like the big question, for all of us. Certainly it's on, my mind when I'm, recommending cannabis because, right, we don't, the FDA hasn't approved any investigational new drug trials. And so there's not been a clinical trial that has looked at, really safety, efficacy, dosing. But there is some literature, which I think is obviously really important that we're looking at. And, the first and foremost thing that you want to remember is you want to start low and go slow. And so it's okay if it takes some time to really find the right dosing for somebody, because you don't want them to get the adverse effect and then they no longer pursue medical marijuana as a medication, which you think could really benefit them. So, I think it depends, right? So sometimes I have patients who have osteoarthritis. So maybe I will recommend first a topical formulation of cannabis. Now, if it's something more along the lines of, nausea, vomiting, what the literature would say, or really actually the literature is mainly for chronic pain. So we'll say that. So what the literature would say for chronic pain is that, again, start low, go slow, and then start with CBD. So start with CBD, like 5 milligrams once daily, maybe twice daily. and, and really kind of build from there. So, maybe build up to about 40 milligrams in a day. If that still hasn't helped, then you're adding in THC. So this is a bit more of a, cautious and conservative. Usually, people respond the best to THC, CBD together. So if you're adding in THC, at that point, you're usually looking at something more like 2.5 milligrams per day to start with, and then kind of working your way up, so maybe the next day you try 2.5 milligrams twice a day. And, if you get to, so edibles, give you a really good, easy way to see dosing. Tinctures also really can help you microdose for people to go slow. But, I think the best way is to really, start with also a THC content is only increasing. If you look at the THC content today compared to 70s, 80s, much higher. And so, people a little bit can go a long way. So if someone was vaping, let's say, it would really be one puff, see how they do, and not really repeat it again, maybe until like, 30 minutes later to see how they feel with that particular dose.
That's some valuable guidance for our NP listeners. What are the routes of administration for medical marijuana?
Yeah, so there's a lot of different routes, or a lot of different products, I should say. There are inhalation. Inhalation's kind of like when you think about, right, when you give somebody an IV medication, right? It goes in quickly. The onset's really fast, really within, 10 minutes, but it doesn't last, as long. It's probably going to last you about maybe they say 2 to 4 hours. So it goes in and out fairly quickly. Now, if you were, let's say, chronic pain and you had, let's say, like breakthrough pain, you want something that's short acting, and inhalation would be something that's short acting, right? Now, of course, maybe they have cancer, and really inhalation isn't recommended for, various reasons. So obviously you want to think about your patient. There's tinctures. Tinctures are really great. Again, as I mentioned, for microdosing. You can just start with, 1 drop. Of course, you're going to have to go to the dispensary. You're going to have to look at the products, get a sense of how many milligrams per, milliliter to really break it down to see what you're getting. And so if it's a tincture, it's going to take about 30 minutes to really kick in, and then maybe it will last about 4 hours. Topicals are great when you don't necessarily want systemic therapy. People use them also not only for osteoarthritis, but people will use it for, muscular pain. And then there are, edibles. Now, edibles, I think is, it's always really important to think about edibles in the way of they have high risk for toxicity if you're not careful. When Colorado first passed, legalized medical marijuana, there was a paper that came out that people went to the ED in higher amounts. And it's because, or at least thought to be the result of people taking edibles. So, they maybe took, 1 bite and they were like, okay, 30 minutes later, not feeling something. And then they take another one. And, 30 minutes later, maybe still not feeling anything. Maybe they're going to feel it until like, an hour and a half or so. But now they're ill because they've taken in too much, because they're thinking, oh, maybe I didn't take a good enough dose, when it actually is that they were not allowing enough time for the drug to become active, in the body after a first pass effect. So, you have to really, really educate your patients about that. We live in a very impatient society, and people want something to happen right away. And sometimes we think, right, more is better. And people can feel ill. They're not going to go into respiratory depression like you would get with opioids, but you can certainly feel very ill in terms of just feeling nauseous, vomiting, or you could be, very paranoid. And so, it's something you have to really be thoughtful of. Also, along the lines of route administration, I think it is important, and this kind of even speaks back to dosing. That dosing that I gave you is really for people who are more cannabis naive. And so, what I would recommend is if they have been using, if they're cannabis tolerant, they are going to need a higher dose. And so that's where there's not really any guidance, right? We have to really get a sense of what have they been using and try to kind of figure out, where to start and how to increase to find the right dosing for them. So we don't have a lot of guidance like we do for opioids.
We appreciate your overview of how medical marijuana can be used. Does medical marijuana interact with any medications?
Yeah, I mean, I think the best that we know really is warfarin. You can see an increased risk for bleeding, so increased warfarin concentration. So, that's something really important to consider. I also think it's really important to remember that cannabis is a CYP 450. Some people call that CYP 450, system drug. And so, it does have potentials for interactions with any of the CYP 450 enzymes that, THC also and CBD also, interact with. So, I think you're going to see a lot of risk C stratification. So a lot of monitoring, certainly anything that's a CNS depressant, alcohol, benzodiazepines, opioids, all of those are going to further suppress the CNS when you're taking cannabis as well, which is also a CNS depressant. So I think it's really important that we remember there's potential interactions, and because, right, this isn't something the FDA has approved, there's a lot of unknowns. And so, while I think cannabis, there's a lot of, important benefits, that unknown aspect, we have to be cautious as NPs in terms of monitoring and educating to the best of our ability.
That's vital information regarding drug interactions. Finally, do you have recommendations on how to better educate ourselves and students about medical marijuana?
I think that if you look at the nursing student article, which I think was Parmalee and Clark, and you look at pharmacy student articles on, their knowledge and attitudes in the medical articles, I mean, there's a clear, lack of knowledge. You even see clinician articles, lack of knowledge, and our patients are using cannabis, right? And how much are we really asking our patients? Are they using cannabis, right? And where are they getting cannabis from, right? It's the CBD from the drugstore. We don't know exactly, right? The FDA isn't monitoring it. So we don't even know if it has, what ingredients specifically are in there. So, we have to, really get a sense of what are our best resources. And, the American Cannabis Nurses Association, the ACNA, is a really good organization that does a lot of cannabis work and has, education activities. They have a scope of practice that, also helps with guiding your practice in terms of cannabis. I think that where I work, there tends to be, somebody who's really interested in cannabis and has a good base of knowledge. And so, if a pharmacist, another clinician who really keeps up to date on cannabis, presents on cannabis, they're a really good person to have in your corner if you have any questions. Additionally, I think a lot of cannabis use is in oncology. And so I think that, there's certainly good articles that come out, from ASCO or MASC that really help give us a sense of, where are we at with cannabis and where are we headed, and what are some clinical pearls. And then, something that I used, also in my paper, and as I was doing research, is a cannabis handbook written by Clark, and she's a nurse who has been part of, cannabis, education. And so I found that book to be really, really helpful to really give you a good base of knowledge. I do think when the FDA hopefully, allows for clinical trials, that's going to ultimately be what's going to be the most helpful. But I can say, and I just, in terms of, I know this isn't resources, but I do think it's really important that we support our patients effectively using cannabis and going, to dispensaries, because cannabis on the street can be laced with fentanyl. And so I think if we're not asking our patients about cannabis, they might end up going to the street and getting cannabis, from somebody who is lacing it with, other substances. So even a base of knowledge of what dispensaries are in your area, if your state requires a medical marijuana card, helping your patient to know where to get a card, or you yourself, in Massachusetts, you can, sign up to be able to be somebody who recommends cannabis for your patients, which allows them to essentially get a medical marijuana card. and they get this marijuana from dispensaries, which are overseen by Massachusetts. And so I feel much better about my patients getting cannabis somewhere where I know and where I know it's going to be as safe as possible versus, getting cannabis really kind of anywhere. I think we have to really be concerned and mindful about that.
Thanks so much for your time today, Clark.
Yeah, thanks for having me. It was great.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal and on X at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.